The transferrin receptor is a transmembrane protein expressed on cells that need iron, with by far the highest density on erythroid precursors in the bone marrow. When a cell is iron-starved, it upregulates transferrin receptor expression to try to capture more iron from circulating transferrin. A small portion of the membrane-bound receptor is continuously cleaved and released into the plasma as a soluble fragment, and this fragment is what we measure as soluble transferrin receptor, or STFR. The brilliance of STFR as a diagnostic test lies in two properties. First, STFR levels reflect the iron demand at the tissue level, specifically the erythroid level, rather than the iron storage state. When erythroid precursors are starving for iron, they increase receptor expression. More receptor gets cleaved, and plasma STFR rises. Second, and this is the critical point, STFR is not an acute phase reactant. It is largely unaffected by inflammation, in stark contrast to ferritin, transferrin, and serum iron, all of which can be distorted by the inflammatory milieu. Combining these properties, in iron deficiency anemia, erythroid cells are iron-starved regardless of why, so STFR is elevated. In pure anemia of chronic disease, the marrow is not actually iron deficient at the cellular level. Iron is present, just sequestered, and overall erythropoietic drive is often blunted by inflammation, so STFR remains normal or only mildly elevated. The STFR to log ferritin ratio, when a patient has both iron deficiency and chronic inflammation simultaneously, STFR rises because the erythroid precursors really are starving, and this is precisely the situation where ferritin would mislead you by appearing normal due to the inflammatory boost. To squeeze even more diagnostic power from these tests, hematologists developed the STFR to log ferritin ratio, sometimes called the ferritin index. It integrates the tissue iron demand signal from STFR with the storage iron signal from ferritin on a single scale. The most widely cited cutoffs come from work by Punnanen and colleagues published in Blood in 1997, which established the framework still used today. A ratio less than 1 suggests pure anemia of chronic disease, meaning STFR is not elevated and ferritin is preserved or high. A ratio greater than 2 suggests iron deficiency, either alone or coexisting with anemia of chronic disease, meaning STFR is up because erythroid cells are starving and ferritin is being pulled down despite the inflammatory boost, or simply cannot rise enough to mask the deficiency. The intermediate zone between 1 and 2 is genuinely ambiguous and may warrant additional testing or an empiric iron trial. This ratio is especially valuable in patients with chronic kidney disease, inflammatory bowel disease, rheumatoid arthritis, and cancer, where ferritin alone routinely fails as a diagnostic test.